We are going to cover around 11 topics today. I'm sorry I couldn't put up the list over here, but we've already got the list in the WhatsApp group. So starting with our first case, depression. We have already talked about depression, but unfortunately this case was somehow missed yesterday. So we'll just do this today and the MMSE as well. So depression, we already have discussed the history that we need to take in cases of depression. The patient comes in when with a low mood. We do take the whole history. Low mood on a scale of 1 to 10, how would you scale it? And then going on to if he's enjoying his daily living activities, any changes in his sleep, appetite, and weight, you do ask about that. Then you go on to any feelings of guilt that the patient has. Then you go on to ask the patient if he feels that life is worth living or not, and suicidal thoughts, and then hallucinations. Okay, the same history we'll be taking in this case. So once we have we have our patient in and we have taken the history, if you just have a look at this case, you are FY2 working in the GP clinic. Stephen Douglas, aged 35, has been divorced from his wife and is in depression. So it's already given to you in the stem that he has depression. He saw the psychiatrist, was given CBT treatment, but he is not improving on CBT. What you must do, talk to the patient and address his concerns. If the patient comes in, you start taking your history. You always need to rule out any patient, may it be this patient, another patient, or another patient. The structure remains the same. It never changes. If you try to do a good history of depression and psychiatric illnesses, and then go on to your MCFMH, and then you go on to your examination, you'll be easily able to handle any case of depression. So this case, the patient comes in and he says that he was divorced from his wife and is in depression. You start taking your history. Anything particular happened just before you were diagnosed with depression? When were you diagnosed? So since he has already been diagnosed with depression, so this is the way you're going to. I can see from my notes that you've been diagnosed with depression. Is that right? Yes, doctor. Since when? What have you been doing for it? I mean, have you been taking any talk therapy or any medications for this? If the patient tells you that I've been taking talk therapy, I was given medications, but doctor, I did not use the medications. All right. Any particular reason that you did not use the medications, doctor? I thought maybe I'll get better with the CBT. So how is the CBT going? The cognitive behavior therapy or the talk therapy? Doctor, it's I feel that it's not helping me. So you keep taking your history first around depression, treatment, and cognitive behavioral therapy. All right, so how many sessions have you had up till now? You need to make sure that if this patient has even taken all the sessions or not. How many sessions have you taken up till now? And how frequently have you taken? Was there any change in the beginning or not? No change at all from the beginning? What do you think could be the reason that you're not getting help? Doctor, I don't know, I'm just not getting better. All right. So you did not take the medication, right? Not, you did not even begin it. Yes, doctor, I did not even start the medication. All right, no worries. I'll definitely be able to help you with that. So you start with your mood questions, which we've already discussed right now. Finish your mood questions. Go to family, friends, forensics, and alcohol, smoking. How you coping with life now? Whom do you live with? Doctor, I live with my girlfriend. Okay, it's good to know that you've already started. You've gone into a new relationship. That's really good to know. How is your new relationship going? That's all good. You talk about all these things, then you go on to ICE, especially. Do you have an idea what could be the cause of not getting help with the CBT, doctor? Most likely that I did not take the medications. Yeah, that can be one of the causes. And apart from that, any particular concerns from today's consultation or expectations, doctor? If you can just give me the medication for this, or you can help me in any other way. All right, I think I'll be able to help you with that. You go on to do the examination for this patient. In the examination, check the vitals, do a head-to-toe general examination, especially just Just do the thyroid examination, especially, if nothing else. What you must do, talk to the patient and address his concerns. So you've already talked to the patient. Now you're going to start with the management part. So Mr. Stephen, yes, as you've already been diagnosed with depression, let me recap a little bit. The depression usually happens due to a chemical imbalance in the brain, and that can happen due to stress or excessive worry. So we can definitely start you on the medication today. This medication will help you come out of this depression, but it takes a little bit of time to start its function, usually around 2 to 6 weeks before it starts functioning. And sometimes while using the medication in the initial days, we can have some symptoms, some side effects like nausea, vomiting, tummy pain, or sometimes sexual dysfunction as well. Do you have any particular concern about the medication? All right, you do not offer him any second line therapy from now within this consultation. Okay, always start with SSRIs. Once you've started the medication, tell him that sometimes patients do suffer from some side effects. So if you do suffer, please come back to us. We'll definitely be able to help you with that. We can change it to second line then. Give him some red flags. Do his baseline investigations if you want to do. If they've already been done early in the previous consultation, then you do not need to repeat them. But do give him red flags, do review him after about 2 weeks, and do give him some reading material as well. This is all you need to do in this case. So reassure him that you'll be fine once you start taking the medication. So it's a very general site of a type of depression case, nothing really very different or specific about it. It's just that he has already been diagnosed. So whenever this patient comes, sometimes doctors fail to reassess. So remember that you always need to reassess the patient. And at this time, let's suppose, for example, after reassessment, you realize that this patient doesn't have moderate depression. In fact, he has severe depression, where he has suicidal thoughts or any thoughts of harming others, then you need to send him to the hospital. We've already discussed all that yesterday. All right, let's go to the next one, MMSE. Where you are FI2 working in a GP. Who the patient is, Ellen, aged 55 years, has booked an appointment with you. Other information about the patient is none. What you must do, talk to her and address her concern. So usually it's telephonic consultation that is there. Once you start your consultation, once you start your consultation, okay, sorry, I was distracted by the messages in the group. I'll read them later. So you start your consultation just the way you need to do the telephonic consultations. You start asking the patient about how may I help you. Once you've done with the telephonic protocol, we've already discussed that multiple times now. I'll discuss that once again. Whenever you have a telephonic consultation, remember that you introduce yourself. You take the details of the patient name, age, and address. Then you ask the patient if he's in a comfortable place at the moment, and in case if the call drops, if you can call him on the same number. You are FI2 working in GP, so this call is in the GP. So hello, I'm Dr. XYZ calling from the GP. How may I help you today, doctor? My daughter thinks that I have some memory issue. She thinks that I am having some sort of dementia. She can be saying anything. So it's the concern of the daughter, which you need to check out on. You start taking the history. Okay, thank you very much for letting me know about it, and I'm happy that you have a caring daughter who is concerned about you. So just to see that what's going on with your memory, would it be all right if I asked you a few questions? Yes, doctor. So have you yourself also felt that you have poor memory these days? No, doctor, I don't think so. So why do you think your daughter thinks so? So you always need to ask these questions from the beginning. You need to explore the thinking of the other person. So why do you think your daughter thinks so? It's just that I forgot her daughter's birthday. So she forgot her granddaughter's birthday. That's the reason her daughter thinks that she has dementia. She has started having memory issues. All right, no worries. Apart from your granddaughter's birthday, have you forgotten anything else at all? Well, nothing that I can think of or recall. All right, let me ask you a few questions. Have you had trouble recalling the names of people who are around you most of the time? Um, do you have trouble recalling any important meetings at all? Do you have trouble recalling any important days which you've always recalled very well in the past? Any important birthdays, anniversaries, or special days at all? Have you ever, so now these are very important questions, the ones that I'm going to say now. Have you ever had, have you ever forgotten the stove open in the kitchen? Have you ever forgotten your keys in the lock, in the entrance lock of your house or something like that? Have you ever forgotten your way back home? So these are the red flags. These are the things that usually happen when the patient is progressively becoming dementic. Okay, and these are the red flags as well. So after asking a few questions, you go on to these a little bit of red flag signs. Why am I calling them red flag signs? Because these are the signs where you think that this patient really might need help. After asking all this, you start asking your Meftosa questions. Any other particular concern, any idea, any concerns, any expectations? Then you go on to Meftosa. Have you been diagnosed with any medical conditions in the past? Especially, you are looking for any neurological disorders or any vascular problems, because we know that Parkinson's disease is related to Alzheimer's and dementia. Plus, many other neurological issues are also related to it. This patient is not that aged that we would consider it to be an aging process or so. And then vascular problems like hypertension or ischemic heart disease are very important for you to know as well as a cause of vascular dementia. So, any medical problems, any medications that you're taking, then if the patient has a family history of dementia, if you smoke, alcohol, these are also risk factors. So smoking and alcohol are also risk factors for dementia. So you do all this history, you've already asked the ICE questions, then you go on to the examination part. So one confusion for many candidates, that do we need to do an MMSC? What you will do here, you will just tell the patient that I would like to do an examination on you, because MMSC is an examination as well. It's a mental state examination, okay? Mini mental state examination that assesses your cognitive function. So you will just verbalize that. I will do a I'll check your observations. I'll just do a overall head-to-toe examination to make sure that you're fine, checking for your neck, your heart, and just checking for your nerves as well. So after that, you'll say that I'll also do a mini mental state examination, a test called mini mental state examination. So it's a test and called as an examination as well. When you do, they will usually give you the findings. Okay, so this patient might say that, doctor, I already got that done, and basically my examination, the nurse did that or somebody did that and it was normal. So if you just have a look here, no cognitive impairment, no cognitive impairment. If MMSC shows a level between 24 to 30. Mild cognitive impairment if the MMSC level is between 18 to 23. And severe cognitive impairment if you grade it between 0 to 17. There are different scales. There's another scale where it is graded as mild, moderate, and severe. And earlier I was going with that, but recently I just got this one, so I thought it's easier to remember. So no, mild, and severe. When you do the MMSC, let's suppose, for example, on the phone, you say that I'll do a mini mental state examination, and the patient says that, doctor, it was done and it was 25. So you know that this patient does not have any cognitive impairment. So you can easily reassure her. Reassure the patient that from what you have told me and the examination that I've done on you, it does not see, you do not seem to be having any cognitive impairment at all. Okay, and even the history that you gave me, that is also suggestive of having no cognitive impairment at all, right? So you reassure her. If she's too much concerned, only if she's too much concerned, then send her to the memory clinic. Else, all that you can do is that help her a little bit, because she's 55, and if she has forgotten the birthday of her granddaughter, tell her that it's very normal for us to forget a little bit of what's going on around us. But if you think that your daughter really did not like that, or maybe she felt that her mother is having some issue, try to maintain a diary, which will help you recall things more better. And sometimes you can also use some applications, some games that really help in boosting the memory. I'll check for the links and share them with you. How does that sound to you? All right, doctor. Thanks a lot for letting me know about this. So over the NHS email, send her the leaflets about dementia. Okay, that's what you need to do in this case. That's all. If you find something, like if she says that the nurse, my neighbor nurse assessed me and blah blah blah, or somebody assessed me and my MMSC was 19, let's suppose, between 18 and 23, it was 19 or it was 20, then you are going to definitely send her to the memory clinic. Any patient between 0 to 23 will be sent to the memory clinic. That's all about this one. All right, so let's go to the next one. Next is dermatology. So we have 4 common cases that can come in your exam as well, and would be helpful for you if you are working in the general practice as well. Very important ones, very easy to remember with small things. If we talk about rashes in general, rushes seem scary to many candidates because you need to have a very thorough knowledge of the rashes before being able to diagnose them easily or diagnose them well. But there are certain differences between all of them, which can help you identify that what it is. Let's suppose before I start on with scabies, I'll just give you an overview of rashes. Let's suppose the patient has a rash on a specific area, sometimes can help you with the diagnosis. The type of rash that the patient has can help you with the diagnosis. and the nature of the rash itself can help you with the diagnosis. Like what? For example, if a patient has rash in the interdigital spaces like this one, or this rash is also present around the wrist and around the ankles, around the joint areas, like inside the joint areas, in the fissures, in the armpit, or in the um, in other joint areas, like at the back of the knees as well. This can be scabies. Always think of scabies. If somebody tells you that, doctor, I have a rash between my fingers, do you have a rash anywhere else? Yes, I do have rash on my wrist as well. Okay. If a patient presents with a rash, now we're talking about measles. If a patient presents with a rash that started around the hairline or behind the ears, and then it started spreading to the rest of the body, it can be measles. Rash with fever. We are talking about rash with fever now. If a patient has presented with an itchy rash with fever, that is at different stages. Some of the lesions are vesicular, some of the lesions are scabbing, some of the lesions are crusting. So this one is chickenpox. In chickenpox, you will find a rash which is always at different stages. Just have a look at this. There is crusting, there is some pus inside. These are small vesicles. So at different stages, if the rash is present at different stages, this is, and it is itchy as well. It started around the, it's called as centripetal rash. It started around the tummy or back, and then spreads to the face and legs. Okay, so this is how you can differentiate between the different types of rashes. Okay, and this is urticaria. Just like mapping all over the skin, this is typical of urticaria, and this usually disappear within a few minutes. Once the patient has had a trigger, trigger can be anything in the environment. It can be some food, it can be some sort of particles in the environment. So we always need to identify the trigger, and it usually disappears in 10 to 15 minutes. So that is pathognomonic of urticaria. All right. So this was just an overview of the rashes. Where did that picture go? Okay, I didn't put a picture of Barbara. All right. Anyways, let's go back to our rashes. Scabies. Where you are FI2 working in the GP, who the patient is, parents of Grace, aged 2 years, have come to you with some concerns. Other information is none. What you must do, talk to the mother and address her concerns. Question can come in this way. Question can come in any way. We should be able to identify that this is scabies. So how do we start? Just with our rash history. I'm Dr. XYZ, one of the doctors working here. How may I help you today, doctor? My child has been having this rash. Can you tell me more about it? Yes, doctor, it started about two days back, and it's really spreading fast, and it's really very itchy as well. Can you tell me exactly where is the rash? It's between his fingers. Anywhere else, it's present on his wrist as well, it can say. Okay, so what type of rash is it? Is it just on the skin, or is it raised above the skin? Well, doctor, I think it's a little bit raised above the skin. And is it itchy? Yes, doctor, it's too itchy. Have you noticed any bleeding or any discharge from the rash? Yes or no, she can say anything, because if due to scratching there is a superimposed infection, then the patient can have some infection as well. So you just ask if there is any bleeding or discharge from the rash. Then you ask the patient if he has been having any pain. Is there any particular time of the day when the rash is more aggressive or the itching is more? Anything that makes it better, anything that makes it worse, is it getting worse with the passage of time? You ask all these questions. Usually the scabies rash is worse at night. Not the rash, the itching is worse at night. And also that after taking the hot bath, the patient will have some exacerbation, just like as eczema. He'll have some exacerbation after taking hot bath in this case as well. So a warm bath in this case as well. So once you've taken that much history, do rule out a little bit of other things as well. Ask this patient that have you used any new creams or lotions? Have you used any new clothes recently? Has he used any new detergent? Have you used any new detergents recently in the laundry? Anything like that. Do you think that he came into contact with any chemical? So you are ruling out contact dermatitis, which can basically occur at any part of the body. So did he come into contact with any new lotions, shampoos, or detergents or medications, or something like that? Always ask travel history, always ask medication history, always ask allergy history and contact history in these cases. Okay, have you traveled anywhere recently? Has he used any medications recently? Does he have any allergies? And did he come into contact with anybody who had a similar rash? And by the way, anybody at home who has a similar rash? Does he go to child care? Anybody, any child in the child care who has a similar rash? Then you go on to your Weinsma questions. Weinsma questions are birth, immunization, nutrition, development, medical history, all those things. We've already discussed them many times. Once you're done with the Mindsma, you go on to examination. On examination, you get a picture, any picture. This looks like the hand of an adult, but just imagine the same in a child presenting with interdigital rash and stuff like that. Once you've seen this rash, you are almost 99.9% sure that this is scabies. Ideally, it is always confirmed with the help of a dermoscope. because you are always able to see the tracts with the dermoscope. Even there's a test that can be done, the ink test, to see the tracts, but usually that's not done in the GP. It's only and only done if you are not sure about the diagnosis. Otherwise, it's not needed. Once you've confirmed the diagnosis on the basis of the history and examination, you go on to the management. Uh, Okay, in terms of examination, do check his observations, especially his temperature. Do an examination of the rash. Look for the presence of any bleeding or discharge. Look for any neck pain or stiffness, because you are ruling out your meningitis also always in rashes cases. Then you go on to your management. Your child seems to be having a condition called scabies. Do you have an idea what that is? No, doctor. Okay, so scabies is a small mite that can sometimes, when infect the human skin, can lay eggs under the skin. These eggs basically lead to itching that your child has. All right, check the understanding of the patient. Please do not worry. It is something that usually gets well after using the treatment. Is it contagious, doctor, or will it spread to others? Yes, it's very contagious. It can spread to other family members very fast. So that's the reason the treatment that I'm going to give you, 5% permethrin, all the family members need to use that. How to use it? All of you are going to use it below the jawline, involving the whole body down below. Okay, so below the jawline, you use it on the whole body down below. Also use it under the the nail beds. Okay, just under the nails as well, so that you are covering every part of the body. Then ask the patient to use it behind the ears and on the scalp as well. Just need to avoid the face, that's it. Right, in elderly people sometimes, who are at risk of Norwegian scabies, which is very bad, can have big nodules as well on the skin. In those, we use it on the face as well, and in small babies as well. So you are going to give the treatment. Tell the mother that you just need to apply it tonight. Leave it at least for 12 hours. From tomorrow morning onwards, he can go to his child care. Okay, so you just need to, for the period of treatment, this child needs to stay away from the child care or from others. Apart from that, there is nothing else that's very important here. You are going to give, after given the treatment, you're going on to the non-medical treatment. What is that? You're going to tell them to put all their beddings and the clothes that have been used either in the sunlight for a few hours, or they need to wash them in very hot water at 50 to 60 degrees. Okay, so this is what you need to, in order to kill the mites in the beddings and the clothes, this is what you need to do in these cases. Once given this advice, advise the mother to cut the nails of the child and give some an anti-allergic as well, so that the child is not scratching a lot and then would be prone to superimposed infections. That's all what you need to do in this case, a child 2 years old with scabies, right? Going on to our next case, chickenpox. Where you are FI2 working in the GP. Who the patient is, Stewart, aged 4, is brought in by the mother. Let's make it easy. Aged 4 is brought in by his mother. What you must do, talk to her and address her concerns. So what do you do in this case? You go in, you greet the patient. We've already discussed the whole rash history once. I'll repeat it once again because we have many rashes cases coming ahead. So you go in, you greet the patient. How may I help you? My child has this rash. Can you tell me more about this rash? Yes, doctor. Where did it start? It started on his trunk. So now see where the rash is starting on the trunk, not between the fingers. So these are the differences that you need to keep in your mind. They will be clues for you in the exam. So what type of a rash is? Doctor, it's just like small vesicles. All right. Any crusting on the rash? Yes, doctor, there's also some crusting. Have you noticed any fever? Yes, he has some fever as well. First of all, root out your red flags quickly. Has he had any neck pain? Any cough at all? No, doctor. All right. So you go on to take your further history. What type of rash is it? Where did it start? Is it getting worse with the passage of time? Anything that makes it better? Anything that makes it worse? Any particular day of the time of the day when the rash is more? You ask all those questions, then you go on to the fever questions. Never missing on that. So how did you measure the fever or the temperature? How much was it? Did you give him anything for it? Did he get better with that? So once you've asked about, usually the temperature will settle in this child. Okay, so she'll be telling you, yes, doctor, the temperature got better, but the rash is there and it's really very itchy. All right. So once it was on the trunk, did it go anywhere else? Yes, doctor. Now it's all over on his legs, on his hands, arms, face, everywhere. The rash is everywhere now. All right, so you start your remaining history. Did he come into contact with any new lotions, shampoos, any new detergents that you've used? Have you used any new medication for him? Any new clothes that he might have used? So your usual differences that you need to rule out in here. Did you travel anywhere recently? Do you think he came into contact with anyone who had a similar rash? Once you does he have any allergies? Once you've asked all these questions, go on to your pine smell question. Anybody else at home who has a similar rash? To ask, are there any small babies? This is a 4-year-old child, right? Are there any small babies, elderly, or pregnant ladies at home? Why is that important? Small babies have not been do not have enough immunity. They can have a very bad rash and then can be life threatening as well. So do ask about small babies. Then going on to pregnant ladies, we already know that it's really very dangerous for the pregnant lady to have a chickenpox rash, because it can lead to some very serious implications for the mother and for the child. Then going on to elderly, again we always need to ask that if it's better to stay away from elderly if they have not already been immunized against it, or they've not become immune to it because of a previous rash, then they can have a bad infection. That's all. After that, you go on to the examination. On examination, you find that this child has a rash like this one. The rash that is at different stages, present all over, on his face, on his trunk, tummy, arms, legs, foot, feet, everywhere. This rash is widespread. It is itchy at different stages. This is typical of chickenpox, and it started centrally at the abdomen or at the back. Once you've done the examination, you've done the observations, then you go on to your management part. So from the information that you've given me and from the examination that I did, it seems that your child has chickenpox. Do you have an idea what that is? Yes, doctor, I do have an idea. All right, that's great. So let me recap a little bit. It's a viral infection that can spread really fast. It is contagious, so spreads from one person to another. We need to be careful. If you came to know in the history that he has come into contact with a pregnant lady, advise the mother to go and tell that pregnant lady, or if the mother is pregnant herself, go and advise her to see her GP or her gynecologist as soon as possible. You are not going to start the treatment of the mother at the moment, okay? So do not take any further history. Just tell her to see her GP to see her GP today or tomorrow as soon as possible. Okay, and tell them that you came into contact with a child with chickenpox. Then you give the treatment for this child. Encourage the mother to give him lots of fluids, keep him well hydrated, because of fever sometimes, and also because of bad taste sometimes the children do get dehydrated. So encourage fluid intake. Uh, Advise her to cut the nails of the child, because he's going to scratch a lot and will then leave some scars and marks on the skin. Advise her to make him do as much rest as possible. Though children are really restless, it's hard to make them rest, but that's what you need to tell her. Do give her some medication for fever, paracetamol, and some anti-allergic for the rash if it is too itchy. Coming to public health, advise her not to send the child to the nursing home or to the nursery for at least 5 days. Okay. And or either 5 days, or you say that till the last lesion is crusted. Once the last lesion, all of the lesions have been crusted, at least only then let him go to the child care or be exposed to other people around. So give her red flags. Tell her that if you feel that the temperature has come back, or the child has pain in the neck and has started feeling a bit dizzy or has cough, please come back to us, because pneumonia, meningitis, these are all complications of chickenpox rashes. So you give her the red flags, and do not need to review it until and unless there's something really serious. So just send her home with some leaflets about the chickenpox, okay, and how to take care of the other family members. That's all about this one. Coming on to our seborrheic keratosis, where you are FI2 in the GP, who the patient is, Nancy James, aged 70, emailed you a picture of a skin lesion. Other information about the patient and is none. What you must do, talk to her and address her concerns. What's the skin lesion? It can be something like this. All of these are pictures of seborrheic keratosis. Okay, you might have noticed these lesions on the back of your grandma or someone old in the family. These are very common. Generally non-cancerous lesions, okay, very common and normally non-cancerous lesions, until and unless you see some changes that are coming in. Okay, so if you get confused, you always refer. Let's go to the history. So this lady who is 70 years old, she has emailed you a picture. You start your telephonic consultation, you follow the protocol of the telephonic consultation and start taking your history. How may I help you? Doctor, I have this, it's one lesion only that she'll come with. So doctor, I have this lesion on my back. I have emailed you a picture of that. Can you please help me with this? Yes, sure, Nancy, I can definitely help you with that. Before I have a look at the picture, so please, before you have a look at the picture, do ask her the history. Otherwise, you will get stuck and confused. I already have seen the picture. Now, what do I ask in the history? Can you tell me what's the problem? Doctor, I've noticed a small mole on my back or on my arm or anywhere, she can say. It can be present basically anywhere, mostly on the back, but can be anywhere. All right, so can you tell me more about this mole? When did you notice this? It has been there for years. All right, and have you seen, because it has been there for years, why is she seeing you now? So have you seen a GP for this before? No, doctor, never. So is there any particular reason that you wanted to talk about it today? Doctor, I've noticed some change in the size of the lesion. All right, so can you tell me what's the size of the lesion? Keep taking your next question from the answer of the patient. So can you tell me what's the size of the lesion? It's just the size of a small pea. All right. And what type of a lesion is it? Is it deep inside the skin, or is it raised above the skin? It's raised above the skin. Is it a single lesion, or have you noticed any lesions in any other parts of the body? Doctor, it's just one. All right. And the site size, shape, what's the shape? What is the surface like? Is it rough or smooth? What's the color? What's the consistency? So side, size, shape, color, consistency, attachment to the underlying structures. These are very important questions. Then you go on to ask the patient, have you noticed any changes in color as well? Have you noticed any changes in the nature of the lesion, like any itching or bleeding from the lesion as well? Okay, so have you noticed any recent weight loss, any lumps and bumps in the body, any night sweats at all? No, doctor. Have you noticed any lumps in any part of the body? No, doctor. So ask all these questions. Just a moment. Somebody asked me that when is the session going to start, but why did that happen? Just give me a moment, please. Okay, we'll continue. Sorry, I got lost. So you ask all this history to the patient about the lesion, then you rule out your red flags by asking these questions. Then you go on to your meftusa. You ask the patient about any medical conditions, any medications that he's taking, any family history of skin-related issues. You can directly ask about cancers as well. There's no harm in saying that. Don't feel a lot reluctant about asking these questions. Everyone is okay with that. If anybody asks me about a family history of cancer, I won't feel anything odd. It's a very normal question for the doctors to ask. So do ask about any family history of cancers, or maybe if you're too shy, you can ask about any family history of skin related issues. Then you go on to your SNAPs history, smoking, nutrition, alcohol, physical activity, and stress. Not in lots of details, but just pick and choose and thus ask these questions and then go on to your examination part. On examination, you'll have a look at the lesion and describe the lesion. Thanks for all this information that you've given to me. Ideally, if you were in front of me, I would have checked your observations as well. So today, I'll just have a look at your lesion. Okay, so it looks like a mole. Yeah, it's raised above the. So you're talking to the patient and say a few things about the mole. Okay, don't be just quiet. Okay, I've seen it. That's it. No. All right, I can have a look at the mole. It's blackish brownish in color. It seems to be raised above the skin, and I can appreciate that there are multiple colors inside. And you told me that it has recently increased in size, right? So you talk to the patient in that way, because you're going to send this patient to the dermatologist within 2 weeks' time. Normally, in seborrheic keratosis, you do not need to send the patient to the dermatologist if you are 100% sure that there's no cancerous element in it. Sometimes, very rarely, these lesions can go cancerous. So whenever you see, according to the NHS, although it's very clearly written in the NHS and CKS, that if you see that there are at least 2 to 3 new changes in the lesion. Let's suppose, for example, there's an increase in the size, there's an increase, change in the nature of the lesion, it has become itchy, or there's a change in the color of the lesion. There are 2 to 3 things, then you are going to change the patient, send the patient to the dermatologist. But in my opinion, because we are not experts and we do not have a dermoscope, for us for us, even if this patient is coming without a change, we should refer, because it's on the basis of the dermoscope only that we are able to say that this lesion is benign. When we know that uh, uh, a particular type of lesion can become cancerous and we do not have a dermoscope, please, it's better to send this patient to the dermatologist within 2 weeks' time. Let it be biopsied. Let it be seen by the dermatologist under the dermoscope. What do we see under the dermoscope? Basically, it's hard for me to tell you over here. On naked eye examination on any lesion, we check for A, B, C, D, E. What's ABCD? You guys must already be knowing that. Asymmetry, borders, color, and then D is diameter, and then E is elevation above the skin. This is something which we see on a naked eye examination, and under the dermoscope, we look for 3 different types of patterns. Any blue-red discolorations inside the lesion, any irregular patterns inside the lesion, and any vessels that are visible inside the lesion. So there are 3 different things that are seen. Sorry, asymmetry of the lesion. That's the third one. Asymmetry means that, for example, if you fold this lesion, this paper, let's suppose it's a paper. If you fold this lesion, if you are able to see the mirror image of the same or not, if all there are all different areas of the lesion are different, it means that it is asymmetric, not in terms of shape. It is overall called as an asymmetric lesion. If a lesion has a same type of color, let's suppose, for example, the small lesion, if you can see on the screen, it's just the same. It is not asymmetrical. This is an asymmetrical lesion. So whenever you have a suspicion, to send your patient to the dermatologist. Don't be an unsafe doctor, because if you don't have an experience in dermatology, it's better to send the patient. That's it. So you are going to explain the condition to the patient. You seem to be having a condition called seborrheic keratosis. All right. It's a benign condition, and it's very common as well in your age group and in white-skinned people. Uh, you told me that you've been having it for a long period of time, and recently you noticed some changes in it. I'm unable to appreciate any changes in the color over the picture. So I would highly recommend that you go and see the dermatologist for this. So I'll give you a 2 weeks referral for this. What do you think about that? All right, doctor. I think that's fine if that's important. Yeah, the dermatologist will see it under the dermoscope. Might consider taking a sample as well. Okay, so you are going to give all this history, all this information to the patient and send him to the dermatologist. If he asks you any further questions, only then answer. What can be the treatment? Uh, well, it's going to be decided by the dermatologist. They might go for something called as cautery, or they might go for a small excision of the lesion. So let them see under the dermoscope, and then they will decide about it. Okay, so don't give a particular way of treating the lesion, because you do not know what's going to be the best for this patient. That's going to be decided by the dermatologist. All right, so that's about keratosis. I think we can take a small break, because after this we have 1, 2, 3, 4, 5, 6, 7. Okay, let's do one more and then take a break. Let's do one more. Melanoma, because this is almost the same as seborrheic keratosis. Almost the same history. Everything is going to be the same. So you go in, you greet the patient, you start taking your history. How may I help you, doctor? I noticed a lesion on my leg or on my arm. Melanomas can be present anywhere in the body. Anywhere in the body. So you start taking your history. When did you note it? Exactly where is it present? What's the site, size, shape, surface? What type of lesion is it? Is it raised above the surface? What's the color? Are there multiple colors inside? Does it have an irregular border? Whatever you want to ask. Don't ask too many questions, because anyways you're going to examine the lesion. Apart from this lesion, have you noticed any lesions at all? No, doctor. Do you have an idea what could be the cause of this lesion? I have no idea at all, doctor. All right, and if it has been there for a long period of time, do ask her, why did you come today? Did you notice any change in the lesion? Any change in the size, not site, the change in the size, shape, surface, consistency, nature, itchiness, bleeding, discharge from the lesion? Ask those questions. Then you go on to your floss questions. Have you noticed any loss of weight or any lumps or bumps in the body? Then you go on to your a few more questions about the possible, because on the basis of uh, the history, you are able to see that, for example, if this patient has, if you are suspecting it to be a melanoma on the basis of the history, to ask him that, have you had any shortness of breath, any headaches, and any tummy pain? Because melanoma very fast spreads to the brain, to the lungs, and to the liver. So do ask these questions as a part of your history. You can ask those in the previous one as well, in the seborrheic keratosis as well, because when you are suspecting it can be a melanoma growing inside seborrheic keratotic lesion, then you can definitely ask these questions in this case as well. So repeating that, you can ask this patient that, does he have any headaches, any tummy pain, or any difficulty or any cough or difficulty in breathing, whatever you want to ask. Then in neftosa, what's important? If he has been diagnosed with any medical conditions, any medications, then do ask him about family history. Very, very important. Do ask him about occupation and exposure to sunlight for 4 to 5 hours every day for a long period of time. If that's in the history, then that's really important. There are certain other risk factors as well, like for example, colored. I think blue eyes, blonde hair, fair skin, and specific ethnicities like Aboriginals in Australia. These are few risk factors as well, but I think it's okay. You do not need to go into those details. If you can, that's definitely excellent. Then you go on to your you've done your meftosa, you've done your eyes, you go on to your examination. This is the lesion. You can see that if you draw a line in the center and fold this lesion, you can't see a mirror image, which is called as asymmetry. Okay, so this is an asymmetrical lesion with different colors, asymmetrical borders as well. A wide lesion, I don't exactly remember the diameter, but I think any diameter above than 3.5 is important, or maybe 2.5. I'll check that and get back to you, not giving you any wrong information. Look for any bleeding, any discharge, or anything like that on the surface. That's all what you're looking for in a. This is a typical picture of a melanoma. So you are usually able to see and think of a melanoma, but may or may not say, whatever you feel comfortable with. I do feel comfortable with saying the name as well, but it's up to you. So you tell the patient that from the information that I've gathered and from the examination that I've done on you, it seems that you seem to be having a skin condition. In the best case scenario, it can be a simple mole or skin lesion that's growing into the skin. But in the worst case scenario, it can be something serious or sinister as a melanoma or as a skin cancer. Whatever you feel comfortable with, say that. Oh, okay. So, doctor, can it be a melanoma? This is not a breaking bad news. Please, guys, remember that it's not a breaking bad news. So don't start breaking a bad news. So is it a melanoma? Well, no, I'm not sure at the moment, but I'm suspecting that it can be something serious like that. So I want to send you to the specialist, to the cancer clinic within 2 weeks' time to be seen, and then this lesion will be seen under the dermoscope by the specialist, and then he might consider taking a sample from it, excise it for any lesions where you are suspecting that this can be a melanoma. The type of biopsy that is done is always excision biopsy. Very rarely they go for shave biopsy or punch biopsy. But usually excision biopsy is the best because we have no idea which part of this melanoma is actually cancerous. So they are going to take quite a big border outside, and then 0.5 mm only outside in the first go. If they find that there is a cancerous thing, then they're going to excise a bigger border. So anyways, you don't need to tell that to the patient. You just send him to the clinic and tell him that they might consider taking some sample by doing an excision biopsy for you. In the meantime, if you notice you have any further lumps or bumps, any weight loss, any problems at all, please do come back to us early. We might consider sending you early as well. Okay, give him some leaflets about skin lesions, different types of skin lesion, and tell him that I can see you once you are free from the cancer clinic. That's all. Okay, okay, I think maybe we can also cover this one if you guys do not mind. Write in the kindly write in the chat box if I can do one more case before going on to the, yes, sure. Okay, 1, 2, 3 more answers, please. Okay, great. Let's go for this last because this is also a skin case. After that, we'll just take a break of 5 minutes. I just want some water. Okay, so you go on to this one. URFI2 in the GP, 5 years old Daniel. It can be 5 years old Daniel. It can be an older person. It can be anyone. So it's nothing about the age actually. Urticaria can present in anyone at any age. Talk to her and address her concerns. So you talk to the mother. Hello, I'm Dr. XYZ, one of the doctors working in this practice. May I confirm your name and age and the name and age of your child? Yes, doctor. How may I help you? Doctor, my child has a rash. Child has a rash. She says has a rash. All right. Can you tell me more about this rash? Well, doctor, this rash, it he had it actually. He doesn't have it anymore. He had it a couple of hours back. He had it, and it was, what type of a rash was it? Where was it? So size, shape, surface. Was it raised above the skin? All those questions. You ask all the rash questions that we've already discussed. Ask him about the TMAC. If he traveled anywhere, if he took any medications, if he has any allergies, if he came into contact with any person who had a similar rash, any new detergents, any soaps, or anything, any triggers that the mother can think of. Ask her, what do you think could be the cause of his rash? Did he go out anywhere to play in the garden? So you just try to find out some causes. And if you are not able to find, she might help you herself, that doctor, yes, he did this, after that he developed this rash. So urticaria can be developed after coming into contact with many different types of particles. It can be due to coming into contact with just some specific types of plastic, specific types of some dust mites, and some allergens that are present in the environment. So you just talk about that, take the history, then you go on to your Binesma question: birth, immunization, nutrition, development, and the surroundings of the patient, and if anybody at home has a similar type of rash as well, anybody who smokes at home, that's what I always want to ask in cases of children. Then the MA history. Once you've taken that, you go on to do the examination. I would like to examine your child. Fever is very important. Just remember, fever and neck pain in any rash case, even if it has disappeared, you want to rule out the red flag things. Okay, so you have a look at this rash. She might give you a picture, or she might not give you a picture. I'm not sure how it comes in the exam situation, but believe me, if a patient is telling you just 2 to 3 things about the rash, you can, with your closed eyes, tell that this is urticaria. What are those 3, 4 pathognomonic features of urticaria? It is just like it has a map-like appearance. It's just like a map if you just have a look at it. Okay, a very geographical appearance of the map, of the rash. It's raised above the skin. It appears after coming into contact with certain things, and it disappears in a few minutes or hours time. The patient, every time when comes into contact with that particular thing, can have a rash. So this mother might tell you that he went to a specific place that day, or he's doing a specific thing which leads to this rash. So there can be something in the history. Even if you do not find anything history, it's very easy to manage it. How are you going to manage it? Thanks for giving all this information, and for letting me do the examination on your child. So from the information that you've given me, it seems that he has a condition called urticaria. Have you ever heard about it? No, doctor. All right. It's a allergic condition of the skin, in which the patients can develop this red raised rash on specific parts of the body after coming into contact with specific allergens in the environment. Whenever it happens, it doesn't last for a long period of time, maybe a few minutes or a couple of hours. It's something not to worry about. But if you ever notice that, so give her the red flags right here, because you're telling her not to worry. So tell her the red flags. But if you ever notice that he develops a swelling in his tongue, so now you're talking about a rash which has occurred due to an allergen, just like uh, happens in anaphylaxis case. So tell her that. But if you ever notice that he has difficulty in breathing or swollen lips and swollen tongue, please do go to the nearest emergency department as soon as possible. So this is how you've done your safety netting. Tell her that we need to avoid the triggers. So if she already doesn't know the trigger, so tell her that next time he develops a rash, please try to find out where he was, what activity was he doing, if he ate something specific. So you're going to say simple things like that. If he wore some specific clothes when he had this rash, he came into contact with something specific. So we need to maintain a diary to look for to look at each and every event whenever it happened to the child. So, so that we can find out the trigger. In terms of medication, usually not needed. But if it is too itchy, I can prescribe you some anti-allergic medication, which you can give to the child only when he develops a rash. That's it. Otherwise, you do not need to do anything. You do not need to review this child. But if it becomes too troublesome, then you can refer this child to the allergy specialist, who might test this child for either 5 or 12 allergies by doing the RAS test or the skin prick test, I think. Yeah. So if it becomes troublesome, only then you can send this patient to the allergy specialist. That's it for this one. Let's take a 5 minutes break and get back to our lecture. See you guys. Hello, everyone. I'm back. Let's start with our remaining cases for the day. All right. So we've got a case of neck lump. Uh, Neck lumps can be of different types. Let's start with an overview of the neck lumps. We only have one case for today. Neck lumps. What's the importance of having a neck lump? When can you think of it to be something serious, and when can you think of it to be something that's not serious? It's just an enlarged lymph node which will get better with the best of time. So a neck lump which is painful, less than 2.5 centimeters in size, and that came after an ear, nose, throat, or chest infection, can just be a reactive lymph node. I'm repeating it. A neck lump less than 2.5 centimeter in size, which is pain to touch, means it's tender, and it came especially after having an infection of the ear, nose, throat, or chest, can just be a reactive lymph node. Definitely, when you take a history, it won't be associated with anything serious, any serious symptom at all. A neck lump which is more than 2.5, don't take the size as a cutoff, because any lump which is cancerous as well, it will at some stage be less than 2.5 centimeters. So let's not take size as a cutoff, but any lump which is big, hard, attached to the overlying skin or to the underlying structures, uh, firm in consistency, and or has irregular borders, is not transilluminant, it did not appear after having any ear, nose, or throat, or chest infection, and associated with other symptoms as well, can be something serious. Okay. Now this lump, the location is very important, whether it is central, whether it's in the anterior triangle of the neck, it's in the posterior triangle of the neck. All these things are very important. Like, for example, certain infections, for example, if you have acute tonsillitis, usually the lymph node enlargement will be in the anterior triangle. If you have infectious mononucleosis, the lymph node enlargement will be in the posterior triangle. So it's very important for us to just have a rough idea of what the lump can be. Not these diseases which I talked about, but rough idea is very, very important, because it gives us confidence. When we do have enough knowledge, it gives us the confidence to perform. That is what is needed. So when you see a person with a neck lump or any lump in the body, the lump history is always the same. There is no difference in the lump history. You go in, you greet the patient, you start taking the history. How may I help you? Doctor, I noticed a lump in my neck. Okay, can you tell me more about this lump? It's on the left side or on the right side of my neck. So it's on one side, it's not in the center. It's on one side of the neck. And when did you notice it? Just a few days back. Okay, since you noticed, have you noticed any changes in the lump? Okay, so basic questions: site, size, shape, surface, consistency, attachment to the overlying skin or to the underlying structures. So repeating again: site, size, shape, surface, consistency, attachment to the overlying skin or to the underlying structures. You can ask a little bit of these questions, not all of them, because you actually will do all of them on examination. Then you want to ask some pressure symptoms of the lump. Have you had any difficulty in swallowing or difficulty in breathing recently, which can be a pressure symptom, the pressure symptom of the lump being in the neck? Then you want to ask this patient, is it painful to touch? Have you had any recent infections, any ear, nose, or throat infection, any cough recently? Okay, then you ask this patient that, have you noticed any changes in the site, size, shape, surface of the lump recently? And Then thyroid questions, because it can just be a prominent nodule in a multinodular goiter. So ask a little bit of thyroid questions as well. Have you noticed any changes in your weather preferences, or any changes in your weight recently, any changes in your bowel habits recently? Then you go on to your flaws questions. Any changes in weight, any changes in any night sweats, any other lumps in the body, any fevers recently, you've already asked. So after that, you go on to your maftosa and eyes. Have you been diagnosed with any medical conditions in the past? Any medications? Any family history of anybody being diagnosed with cancers or neck lumps or anything like that? Family history of thyroid issues or any cancers? You can ask like that. Then you go on to your smoking, nutrition, alcohol. You know that smoking is very important for you to address in this case. He can be having a cancer. It can be cancer of the lung. It can be cancer of any part of the body which is appearing here, or it can be a lymphoma. It can be anything. We have no idea. So don't give a diagnosis of this lump. Just do your history, do your maftosa, do your eyes, go on to your examination. In the examination, you start with the observations as usual. A normal temperature will take you away from a reactive lymph node, pointing towards something serious and sinister. Then you go on to your examination of the lump. When you examine the lump, you do say a little bit, as we said in the seborrheic keratosis case. Okay, I can see that the lump seems to be present in a little bit posterior part on pretty side of your neck, and it's pretty big in size, the size of a small ball, and seems circular. Okay, so whatever you visualize, say all that, and then when you are palpating the lump, it's not an examination station, so you won't be able to say all that. If you get the finding, just say that I've examined your lump. So now you are reading on your note and you are telling the patient what you have examined. I've examined the lump. It's really hard to touch. It's not mobile. It's around 4 centimeters in size, and it's present in the posterior part of your neck, in the side of your neck, sorry. And because he doesn't understand the posterior triangle and stuff like that, so you just say on the side of your neck. And it's when I threw some light into it, it showed that there is no fluid inside. So explain a little bit if you want to, just like that, if you think that you have enough time. Once explain, tell the patient that, well, you've already taken the ideas, concerns, and expectations and the history part. So now you're going to manage this patient. So from the information that you gave me and the examination and that I did on you, it seems that uh, you might be having something as simple as an infective lump that comes after some sorts of infections, but you told you did not have any fevers recently. So I'm a bit concerned about this lump because it's also hard to touch and it's fixed to the underlying structures. So I want you to be seen by the specialist within 2 weeks' time. Doctor, is that something serious? What sinister are you suspecting? What sinister thing are you suspecting? Well, it can be sometimes related to some sort of cancers, but I'm not sure at the moment since we do not have any tests for you. So what I can do now is that I can arrange an ultrasound for you and your baseline investigations today, and I'll refer you to the specialist to be seen within 2 weeks' time. Once you're at the specialist place, you might consider taking a sample from this lump and send it to the lab to be seen under the microscope to find out what it exactly is. How does that sound to you? So send for all his investigations, send for his DSH, CBC, LFT, RFT, everything. You are the one who is going to decide that how much you are going to say in terms of investigations and in terms of explanation, because you are going to manage your time very well in your own way. So once you have done that, give him some leaflets about neck lumps. Give him some. Tell him that if you have any further worsening of symptoms within these 2 weeks' time, please do come back to us early. We might have to send you to the specialist early as well. All right. So that was about neck lump. Going on to idiopathic thrombocytopenic purpura. Patient can come with different presentations. This patient can come with a rash that is a non-blanching type of rash. This patient can come with bruises on the body, and very, very rarely, very less likely, this patient can come directly with bleeding from any part of the body. So what is idiopathic thrombocytopenic purpura? It's basically a reactive decrease in the platelets, thrombocytopenia, which usually happens after some sorts of viral infections. Okay, so when this patient comes to you, doctor, I have bruises on my body. All right, can you tell me a little bit more about it? So you know that his skin is bleeding actually. Okay, what are bruises? It's bleeding inside the skin. So you start taking your history. Okay, can you tell me more about this bruises? These bruises, exactly where have you noticed? How many are they? Have you noticed that they are improving with the passage of time, or are they increasing with the passage of time? Apart from these bruises, have you noticed anything else? No, doctor. Then you start your closed-ended questions. Have you noticed any bleeding from any part of the body? Have you noticed any pinpointed rash on any part of your body? Then you start after bleeding from all parts of the body, and bleeding from the nose, from the mouth, from your back passage, from your front passage. You ask all those bleeding questions. Then you want to ask this patient about any recent infections that you've had. So now, since it's bleeding, definitely in the meftosa part, you're going to ask about any bleeding disorders and any blood thinning medications. So before that, in the history part, do ask about any recent infections at all. Have you had any fevers at all? Fever with any rash or bruise? Do ask about fevers always. Any pain in your neck? So you are ruling out your meningitis. Why? I'll tell you why. Even in this one, though it's coming with a bruise, when these people, they have a rash, if they come with a rash, then they have a specific type of rash. When you do the glass test for this rash, it does not blanch. So a non-blanching type of rash in these patients is present, and this rash is the same type of rash which is also present in meningitis. So you ask all these questions, you go on to your meftosa. This patient might tell you that, doctor, I had a recent flu or recent chest infection or something like that, right? So you go on to your next history. You ask this patient about meftosa, any medical conditions like any blood disorders or any blood thinning medications, any family history of blood disorders. Then you ask this patient any tummy pain as well as a part of your history. I completely forgot to ask that, to say that. So tummy pain, and whenever a patient comes to you with bruises, to ask about tummy pain and tummy distension as well, right? You go on to your and lumps and bumps in the body as well. You go on to your eyes, and then you go on to your examination part. In the examination, you have a look at the rash or the bruises, whichever he has. You just generally have a look at the patient overall, if he looks dehydrated or cachectic, or if there are any signs of active bleeding from any part of the body. Overall, you do not need to specifically examine all the areas, all the openings of the body, but you do that, and then you want to do your. You do not need to in the examination part. You do not need to do the CBC, because that's not a part of examination. In the examination, you can do any office tests that you want to do, but otherwise nothing else. Okay, all right. Then you go on to your management. So you tell the patient, from the information that you've given me, okay, I'm so sorry. In the examination, don't forget to do the tummy examination, because splenic enlargement is one of the consequences which needs to be addressed in the management part in any case of idiopathic thrombocytopenic purpura. How is the diagnosis going to be confirmed? You are going to do the platelet count for this patient, and do send for other baseline investigations as well. So you start with your management. So from the information that you've given me, and from the examination that I did on you, on examination, you've only found bruises, and on history, you only found that this patient had a recent flu-like illness, and after that, he has developed this rash. He doesn't have, he may or may not have bleeding from any part of the body. So you go on to do your management. You seem to be having a condition called idiopathic thrombocytopenic purpura. We can, in the short form, call it ITP. It's a condition in which the level of platelets in the body markedly decreases because of reaction to a recent infection which you had, right? Usually, it can be managed very well at home, but it depends on the level of platelets that you have. So what we need to do now today, if you think that the symptoms are very severe, you can send this patient to the hospital, because you have no idea in the practice that what's the level of the platelets. When you say that I will check your do all your investigations, involve my senior, and see what's the level of your platelets, and if the examiner gives you that the platelets are very low, they are below 50,000, you need to send this patient to the hospital, because platelets, when they drop below 50, they can markedly drop below that very very fast. I'm sorry. Once around 10,000, the patient can actively bleed as well. So be aware of that. It's not necessary that he'll definitely bleed, but he can bleed. So it's very important that we take care of these things. If it's a child, then it's very, very important that we take a little bit more care of this child, because he'll be restless, won't be listening and stuff like that. Otherwise, if the patient is stable, the platelets, you do not get any level of the platelets, you definitely send this patient to the emergency department. If you get a level of the platelets which is around, let's suppose, for example, this is 60,000 or 80,000, you can send him home, but give him some advice. Ask him to avoid any types of contact sports. Tell him that it's going to get better on itself. You do not need to take any particular medications for this at this point in time. Just keep yourself well hydrated, avoid any infections, avoid any trauma to any part of the body, because the numbers of platelet have decreased. So we do not want you to have any active bleeding from any part of the body. If the platelet level has gone pretty down, then you can simply admit him. We've already talked about that. He'll never ask you that what's going to be done in the hospital, but if he does ask you, then steroids and then some immunoglobulins would be given to him in the hospital. So this is idiopathic thrombocytopenic purpura, primary immune thrombocytopenia. Most often it's acute. Very rarely it can be chronic. So what does it mean by chronic? Actually, it's written that in 20 to 50 years old, it can be chronic. So basically, if any adult, it's just a part of teaching, it's not related to your GMC exam. Any adult who has a recurrent idiopathic recurrent attack of ITP, we always need to look into autoimmune diseases. There can be some underlying disease, which is usually the case in adults, not in small children. Okay, in small children, usually it's just as a reaction to the infections and no underlying disease is present. So you can reassure the parent that in almost 90% of the people, it never appears again, right? Very rarely, if it does appear again, we always need to investigate further to find for the cause. So clinical features, what can be there? There can be a petechial rash, gingival bleeding, epistaxis, menorrhagia, GI bleeding, and intracranial bleeding. So we've already talked about this type of bleeding. Management is supportive. Platelets only for severe bleeding or extremely low platelet count. Corticosteroids can be given, immunoglobulins can be given, and splenectomy. That's the last resort if the patient is not improving at all. Causes of non-blanching rashes. I don't know whether you guys will be interested in it or not, but this is something really very, very important for you to know as a doctor. Causes of non-blanching rashes. This rash, the ITP rash, is basically a non-blanching rash. What is blanching? When you put pressure on the rash, it blanches, it spreads in the surrounding tissue. Okay? A rash which is just like small pinpoints, and it's not blanching. The glass test is negative. This type of rash is called as non-blanching rash, and these are the causes of non-blanching rashes. So meningitis, Henoch-Schönlein purpura, idiopathic thrombocytopenic purpura, hemolytic uremic syndrome, forceful coughing and vomiting, and non-accidental injury. These are the causes of non-blanching rashes. Amongst these, just have a look at the meningococcal sepsis. It means that when a patient is coming to you with ITP, it's very important that you ask him some questions to rule out that this is not meningococcal sepsis. This is not meningitis. Okay. HSP, what questions can you ask if you want to rule out HSP? You can ask about any tummy pain, because incarceration is intussusception, sorry, is very commonly related with HSP, and joint pains are very commonly related with HSP. So you can ask about joint pain. ITP itself is the picture in front of you. Hemolytic uremic syndrome, it's going to be a very long thing. Then just ask this much: if you have had any fever, if you have any neck pain, and if you have any tummy pain or joint pain. This is going to be more than enough as a DD in case of idiopathic thrombocytopenic purpura. All right. Okay, so going on to the next topic, that is obstructive sleep apnea. Oh, good. So we just left with two, I believe. Yeah, that's it. Obstructive sleep apnea. What is obstructive sleep apnea? First of all, we need to know what it is. It's a condition where there is an obstruction to the airflow inside our mouth. When can that happen? When a patient has, when a patient is obese, when a patient has a long history of having tonsillitis, having hypertrophied adenoiditis history. These conditions can lead to obstructive sleep apnea. What actually happens is that, okay, let me just do the whole case and then come to the explanation. It would be better in the management part. So who you are, the patient, how can this patient present, this obstructive sleep apnea patient? He can present in many different ways, but tiredness and excessive sleepiness is are one of the, are a few of the, a couple of the most common presentations. So he might come with a sleep problem, or he might come with tiredness. So you start taking your tiredness history. As we always know that in the tiredness history, we at a point do need to ask about sleep as well. So you start your history. Hi, Mr. XYZ. I'm Dr. Noor, one of the junior doctors in this practice. How may I help you? Confirm his name and age. Doctor, I have been having this tiredness. Right? Can you tell me more about this tiredness? Yes, doctor, I've been having it for a while now, and it's really distressing. It's increasing with the passage of time. He has given you some information. So apart from that, start asking your closed-ended questions. Can you tell me, what do you exactly mean by tiredness? Well, doctor, I feel fatigued all the time. I feel tired all the time. All right. And is there any particular time of the day when you feel tired? It's in the morning or night or evening after doing your works. And when did it start? It started, let's suppose, four months back. And anything particular happened 4 months back? No, doctor. In this case, he'll say no, doctor. Nothing particular happened. Then you go on to your anything that makes it better, anything that makes it worse, and then you do a complete systemic check in cases of tiredness. Ask him that apart from this tiredness, have you had any problems with your whole day? I mean, any problems with your concentration? Any problems doing your work? Then how you sleeping? How is your sleep? Well, doctor, I sleep very well. All right. Even if he says I sleep very well, many of these apneic patients have no idea that they go into apnea at night. So please do ask, has anyone in the family noticed that you snore a lot? Well, yes, my wife thinks I snore a lot. All right. Since when has that been? It has been about 2 years now, 3 years now. All right. And has it increased with the passage of time? Has anyone ever noticed that you temporarily stop breathing at night, or have you yourself noticed anything like that? He might say yes or no, or he might say that yes, my wife noted, or my partner noted, or somebody noted. All right, so you already almost got your diagnosis here, but you keep going. You ask him that, okay, apart from this, have you been feeling sleepy in the daytime? Yes, doctor. Since when? It has been about 2 years now. So how is it affecting your life? It's affecting my life a lot. You do a complete systemic history quickly because you still want to rule out other causes of tiredness. So have you had any headaches recently, any shortness of breath, any cough, any fast racing of the heart, any tummy pains, any joint pains, any loss of weight or increase in your weight? Yes, doctor, I had my weight increased recently. In OSA, patients who are overweight can have OSA, and patients who have OSA can gain weight. So it's a vicious circle that goes around. So he might be having some weight changes as well. Then go on to your meftosa. Occupation is very, very important. Try to find out that this patient should not be a taxi driver, because DVLA recommends that they should not be driving if they have a particular score for a special uh, scoring system that's done for these patients. So you do ask them about their occupation as well, and how is it affecting their life. You go on to your eyes, then you go on to your examination. In examination, if you just give me 1 second, I can show you something very interesting. uh, okay, I'll just show that to you. Okay, this is the new slide. So let me just put it over here so that it's there for the next session as well. So this is the Malampati score. Okay. So when you on the basis of your history, you are suspecting that this patient has OSA. You are suspecting that this patient has OSA. You start doing your examination. Thank you very much for all this information. I would like to do a quick examination on you, checking your vitals, checking your height, weight, and BMI. I'll also do a complete ear, nose, and throat examination for you. Also do a complete head-to-toe examination, including your joint examination, tummy examination. Do take the neck circumference, and do take the abdominal girth of the patient. Okay, these are important for you, because any obese patient is at risk of developing OSA, and similarly, any patient with uh, with this problem of snoring and lack of concentration and stuff is at risk of developing OSA. So you do all those things and you come on to your Malampati score. You say that I'll do an ENT examination. You do not need to say this score. I've put up this score over here just for your clarification. This is a normal throat. See, the air can easily go in the throat. This is getting obstructed gradually. So we know that it's an obstructive sleep apnea. It is getting further obstructed, and now it has almost completely obstructed, and you are unable to see the pillars and the tonsils or anything at all. So it's a score which helps us have an idea almost about what's going on with this patient. So complete visualization of the soft palate is here, complete visualization of the uvula is here, complete visualization of the base of the uvula, and soft palate is not visible at all. So this is Malampati score. This is the extreme condition where the patient is even sleeping in the queues, where sometimes you find that this patient sleeps anywhere, watching TV, while driving, while at the intersection, anywhere. This patient can sleep anywhere. He sleeps so less at night that he's sleepy whole day. So you do an ENT examination. You you have already done the remaining examination for this patient, and then you explain the condition to the patient. So thank you for coming in today. From the information that you gave me and the examination I did on you, it seems that you have a condition called obstructive sleep apnea. Do you have an idea what that is? No, doctor. It's a condition where there is an obstruction to the flow of air into your mouth, and when your muscles, the muscles of your throat, they are relaxed at night, this obstruction increases. Okay, so normally he has no obstruction, which increases on sleeping at night. Tell him this. Tell him that all your symptoms of snoring, of getting up in the middle of the night and feeling short of breath, and then sleeping in the daytime, and also sleeping on the traffic signals, all these are very um, are pointing towards this condition. So for this, now what you're going to see, you're going to refer him to the sleep clinic, where the sleep study would be done for him. Once the sleep study is done, there's a score that we will get from the sleep study, that is called as apnea hypopnea score. That score will decide whether this patient can just go on with lifestyle modification, or if this patient needs some CPAP, some assistive devices to help him breathe better at night. Okay, so do not talk about very invasive treatment. Just send him to the sleep clinic for sleep study, where once the sleep study will be done, then specialists in the sleep clinic themselves can decide what he needs. Okay, so do not worry about that. Do ask him not to drive for the time being, because it can be dangerous for him and for the family, for other people on the road. And once you're diagnosed with the condition, I would highly advise you to inform the DVLA about it. Okay, that's about it, because there's a score called as Epworth uh, sleepiness score, I think, ESS, Epworth sleepiness score. I don't exactly remember the name now. It's just fading out of my memory. So that score is used in which there are about 20 or so questions which you ask to the patient, and then score the patient accordingly. And then you send him to the sleep clinic. Okay, that's it about obstructive sleep apnea. Chronic fatigue syndrome, almost the same, not much different in terms of history. Otherwise, definitely, it's completely different. You are FI2 in the GP. Mr. Khan, aged 45, presented with tiredness. He has been to the hospital 6 months ago with the same problem after having flu. The IT system in the clinic is crashed. You do not have any medical records of the patient. What you must do, talk to the patient, take history, and discuss about the management plan with the patient. Address patient's concerns. Special note, patient presented to the GP 6 months ago because of the same problem. Why have they given this complex thing in the end of 6 months, and then also told you that the IT system has crashed? Is there any particular reason? Yes, there is a reason behind giving this information. It means that this patient has been having continuous tiredness for the past 6 months. Whenever you hear of a tiredness that is continuously present for the past 6 months, always think of chronic fatigue syndrome. Because in order to diagnose chronic fatigue syndrome, the patient should have a history of 6 months at least. So that is a must. And also, you need to exclude other causes in order to diagnose. So any tiredness lasting 6 months or more, and you've excluded other causes, this can be CFS. You go in, you greet the patient, you start taking your history. How may I help you today? I'm Dr. Noor, one of the junior doctors working in this practice. May I confirm your name and age? How may I help you? I've got tiredness. I can see from my record that, always paraphrase this thing which is here for you. I can see from my records that you also came to the clinic about 6 months back. Is that right? Yes, doctor. So may I know what happened? At that time, I also at that time also I had tiredness, doctor. All right. And apart from that, anything else? What was diagnosed at that time? Were any tests done for you at that time? So you ask those general questions to this patient, because this is the same patient who came 6 months back as well. So first take a little bit of his history of his past visit to assist yourself in the next history. So once you've asked that, you go on to the tiredness questions. Okay, can you tell me about your tiredness? Since it has been there for the past 6 months, has it increased with the passage of time? Is there any particular time of the day when you have more tiredness? Anything that makes it better or anything that makes it worse? Anything particular happened 6 months back? No, doctor. All right, I can see from my notes that you had a flu about 6 months back. Is that right? So you reconfirm this thing over here for yourself if it is there in the question. Oh, yes, doctor, I did have a flu at that time when I came to the doctor 6 months back. All right, you go on to take your remaining history. You still need to rule out your different source. That is the important thing here. He's a 45 years old man. He can be having something else as well. So you can't just think of it to be CFS and go away with it. Okay, so can you tell me, have you had any recent, go to your flaws first, any fevers, any loss of weight, loss of appetite, any lumps in the body, any shortness of breath, and all those things? Okay, I'm really sorry. In terms of tiredness, when you're taking the history, the patient might tell you what is very typical of chronic fatigue syndrome is that, doctor, I get tired after doing minimal activity. So this is typical of chronic fatigue syndrome. Remember, patient wants to stay in the bed most of the time of the day. That is about chronic fatigue syndrome. Okay, it usually starts after some sort of infection. Chronic fatigue syndrome, that is the reason it's also called as viral fatigue syndrome, because it usually is preceded by a viral infection. So remember like that. Once you've taken that much history, you go on to your systemic history, then to your maftosa and your eyes. Then you go on to your examination part. The examination is going to be just the same way as we did the previous examination. Do the whole examination, head-to-toe examination, including observations, ENT examination. You must also have asked about sleep in this case, because history is going to remain the same in all tiredness cases. Then you go on to your systemic examination and do the management. All right, thank you for coming in today. From the information that you've given me and from the examination that I did on you, it seems that you might be having, it's not that you are having, you seem to be having, you might be having a condition called chronic fatigue syndrome. Do you have an idea what that is? No, doctor. Well, it's a condition in which there's a fatigue or tiredness because of no physical reason, no medical reason to it. Usually when this tiredness lasts for a period of more than 6 months and it is preceded by a flu-like illness, and if we do not find any cause, we call it chronic fatigue syndrome. Since you came here 6 months back and you told me that some tests were done for you, so this patient might tell you that some tests were done for me at that time, but I did not come back for the reports. So since you told me that 6 months back some tests were done for you and you did not come for the reports, unfortunately, I'm really sorry to tell you that the IT system in our clinic has crashed today, and I'm not able to access your reports. So what I can do for you now is that we will need to reconfirm your test by doing again. So you're going to do the investigations today, compare them with the previous investigations, and then treat him for chronic fatigue syndrome. Give him, tell him that there is no medical treatment to it, but there are certain lifestyle changes which can help you a lot. Taking a balanced diet, doing enough of supervised or not supervised, graded exercise. Tell him, please do not do any heavy exercises, do not join any gym for a heavy exercise. But if you join a gym, try to tell your trainer that you will only need to do a graded exercise, in which gradually he will increase the level of exercise over weeks to months. And in the daytime, I would highly advise you to take short naps, not lasting more than 30 minutes, maybe 2 to 3 times a day. They will really help you a lot. That's all. That's all for chronic fatigue syndrome. Give him some red flags. This patient and the previous patient of OSA. If you notice that you have any loss of weight, or if you have any fevers or lumps and bumps in the body, please do come back to us. We might need to look into other causes of your tiredness. All right, give me a minute, and then we'll go on to the question and answer session.